good afternoon, good evening for people that have just joined. We do have interpretation available, so please select your preferred language under the interpretation button on your screen. So welcome to the Testing the Context Assessment Toolkit, Supporting Facility Readiness to Adopt Change webinar, hosted by the Momentum Monitoring Evaluation, Innovations, and Learning Working Group. I'm Gabby Nguyen, a policy advisor at Population Reference Bureau, and I support the Momentum Knowledge Accelerator project. For those who are not familiar, Momentum Knowledge Accelerator is one of 6 distinct yet related projects that make up USAID's flagship Momentum project. The Momentum projects work with governments and institutions in USAID partner countries to accelerate reductions in maternal, newborn, and child death and disability. This is achieved through supporting countries to strengthen the capacity of community and health systems to deliver, scale up, and sustain the use of evidence-based, high-quality maternal, newborn, child health and nutrition, voluntary family planning, and reproductive health services and care. Momentum Knowledge Accelerator specifically facilitates learning, adaptation, innovation, knowledge sharing, and communications for the Momentum projects. And today, the Context Assessment Toolkit that we will be discussing was implemented under the Momentum Knowledge Accelerator project. So today we'll be introducing the toolkit itself and how it's being integrated into quality improvement initiatives, how we piloted the Context Assessment Toolkit in Indonesia and Ethiopia, and then we'll be discussing the evaluation of the toolkit in select low resource settings, and then provide key recommendations and next steps for the use of the toolkit. Next slide, please. Thank you. So today I have the honor to be the MC for our webinar today and be kind of facilitating a discussion with our panelists here, who include Siti Nurul Kumaraya from Jepago, Indonesia, and the Momentum Country and Global Leadership Program, Megan Ilam, Implementation Specialist with Ariadne Labs, Adam Lindsley, Senior Project Manager of Ariadne Labs, and Megan Marks-Delaney, Research Scientist with Ariadne Labs. So now I'll pass the microphone and video on to Adam.
Thanks, Gabby. So we are going to start today by talking about why context matters when implementing a practice improvement before going into more detail on what the Context Assessment Toolkit is and what it aims to do. So as many of us may have witnessed, despite our best intentions, sometimes healthcare sites fail to integrate solutions into practice effectively and sustainably. And we know that evidence-based solutions to improve care can be transformative when they're implemented successfully, but adopting those new tools and changing behavior can be challenging. In fact, up to 60% of all efforts to introduce innovation in healthcare either fail to be implemented or cannot be sustained. In some cases, standardized implementation processes that work for some facilities often don't work for others. We believe that contextual factors at the facility level, things like leadership, staff motivation, quality improvement experience, can influence adherence to evidence-based practices. And with the implementation of quality improvement initiatives increasing in low and middle income countries, the role of context is not usually adequately addressed. Most facility readiness assessments we found fail to address these contextual factors adequately, leaving blind spots for implementation of a change to healthcare practice. So this is all grounded in the theory that aligning implementation processes with a facility's context by adapting to the reality on the ground, improving modifiable areas, and leveraging strengths can help program implementers introduce practice changes more effectively. So the Context Assessment Toolkit is a structured approach to identify and help address some of those facility level factors that might influence the success of implementing a practice change. It was developed here at Ariadne Labs and is being adapted for low and middle income countries through Momentum. As an example of where the impetus for this work came from, when the WHO Safe Childbirth Checklist was introduced in 60 healthcare facilities in India using a highly standardized implementation strategy, there was significant variation in the number of essential birth practices adopted by those sites. And what we saw was that the implementation approach and tool were constant, but the context varied. And when we really looked into the data, there was not one explanation that accounted for the results. Instead, it was discovered that a variety of factors, such as a lack of provider knowledge and skills and unclear communication between team members, interacted with each other to create an environment that was less ready to implement a practice improvement. So the information learned from the Context Assessment Toolkit is hypothesized to make implementation more successful by allowing users to adapt their strategy to the unique context at a facility by identifying their strengths and areas for improvement. And the toolkit assesses a facility's ability to implement, leadership commitment and motivation, internal culture and teamwork. And together, these domains make up the context in which a program or intervention is being implemented. So it's important to first understand where the use of the Context Assessment Toolkit might fit into the overall timeline for a quality improvement project. So quality improvement work typically starts with defining the problem affecting patient care and coming up with the solution. And the toolkit really helps with understanding the current state of the facility. So these pink boxes, so you can modify the solution or implementation strategy to better align with reality. And oftentimes it's used alongside other facility readiness assessments in order to get a more holistic view of a particular site. We're going to discuss some more around timing of the toolkit in a bit, but I just want to quickly touch on its components. So the toolkit includes 3 surveys and a set of conversation guides to be administered at different time points throughout the implementation of a change of practice. The tools are ideally meant to complement each other, but there is some flexibility. We'll explain more about this later, but the tools that were assessed as part of this evaluation were the pre-implementation survey and the conversation guide, so the top 2 rows of this table. The context assessment is completed by leaders, healthcare workers, and implementation team members from the facility at various time points throughout implementation. You might also involve the patient population or community in this process as well. And this is a sample suggested timeline of the ideal use of the toolkit. But as we'll hear in a bit from Bunarol later on, their experience differed a bit from what is listed here. I also want to call out that the pre-implementation survey and the conversation guide components are meant to take place before or during early implementation, when you can receive and analyze the data and actually act on that information. So Momentum Knowledge Accelerator evaluated the acceptability, the feasibility, and perceived utility of the toolkit by partnering with Momentum Awards and others in piloting the toolkit. The 2 partners that participated in this evaluation were Momentum Country and Global Leadership in Indonesia, that they're working on a hospital mentoring and facilitative supervision intervention in health centers, and Lifebox's Clean Cut program in Ethiopia, which is conducting an adaptive intervention to improve adherence to essential infection prevention practices to minimize surgical site infections. So both implementing partners rolled the context assessment out in 10 facilities each. I'm now going to pass it off to my colleague Megan Lam, who will talk more about the piloting of the toolkit in Indonesia and Ethiopia.
Thanks, Adam. So in this section, we'll talk about the preparation for and use of the Context Assessment Toolkit in Indonesia and Ethiopia, and then we'll get into the results that came out of using the toolkit during the pilot period in these 2 settings. Next slide. So here you can see the timeline for the adaptation and use of the Context Assessment Toolkits in both Indonesia and Ethiopia. Work on the context assessment began in October of 2021 with obtaining local ethics board permissions, survey customization and translation, followed by training. And the pilot period wrapped up in July of this year with coaching for the 2 pilot implementing partners on the results from the context assessments at each of the facilities. As with most healthcare programs during this time, the COVID-19 pandemic disrupted implementation of the toolkit and the local improvement initiatives, but both of our teams were able to proceed with most of the activities. As you can see here, Momentum Knowledge Accelerator, which is indicated by the light pink boxes, primarily supported implementing partners with guidance on toolkit administration and facilitation at the beginning of the pilot period, before working with them further on results interpretation and dissemination back to the facilities at the conclusion of the pilot period. Next slide. So information collected from the surveys and the conversation guides were translated into areas of strengths, variabilities, and challenges. For the pre-implementation surveys, programmatic and facility level reports were generated for both the CleanCut and the Indonesia teams. Common themes across all of the facilities included in the CleanCut and Indonesia programs were categorized as areas of strength, areas with variability or misalignment, and challenges. A heat map was generated using this information to quickly show our implementing partners how each facility was doing compared to the average performance on each theme. Momentum Knowledge Accelerator helped both implementing partners review and categorize the results in the same way for each of the facilities participating in their programs. For the results of the conversation guides, Momentum Knowledge Accelerator looked at both the quantitative scoring component when it was completed and the qualitative summaries to identify, again, areas of strength, variability, and challenge. We also looked at the action plans that were created as part of the conversation guides to get a sense for what facilitators saw as priorities to be addressed throughout the improvement work. Next slide. So when examining the results, we found that the context assessment tools revealed strong commitment to and interest in the local improvement interventions across both the Momentum and the CleanCut programs. When looking at the pre-implementation survey results, facility staff from both programs agreed that there was strong leadership commitment to the improvements and a good understanding of and buy-in to the aim and purpose of the improvement work. Additionally, both sites reported strengths in categories related to teamwork, including that facility staff at both programs knew their roles and responsibilities, as well as who to go to when they needed help with patient care. We also saw that overall results from the conversation guides identified similar strengths related to teamwork and communication, as well as leadership commitment and prioritization of various improvement interventions, which indicated that facility staff responded similarly to both the pre-implementation surveys and the conversation guide tools. Next slide. However, gaps in accountability, perceptions of quality improvement work, data systems, and resources could hamper implementation success in both programs. While survey results were very positive overall, a higher proportion of facility staff selected a negative or neutral response on questions related to accountability, data use, and respect associated with quality improvement work. Compared to formal leaders, facility staff with a clinical role felt that there were lower levels of accountability for practice improvements, as indicated by the differences in responses for questions such as, are leaders stick with the with practice changes throughout the ups and downs of implementation. In general, staff are assessed on how well they do practice changes, and new programs and changes are integrated into our routine work. Further, just over half of all of the facility respondents that felt that quality and safety data were used in patient care. And you can see here with the black rectangle that there were similar levels of agreement across all respondent roles for this question. Next slide. So here you'll see a heat map that was developed to evaluate key themes across all of the Momentum Program facilities. As you can see, the pre-implementation survey responses from each facility were compared to the average response across all facilities, which is this top row here. Facilities that had a given theme as a strength were coded in the purple color. Those with variability in their answers to questions in a given theme were coded green. And those with significant proportions of negative responses to questions in a theme were coded as red, which indicated a challenge area. The cross-site analysis of the Momentum Program surveys depicted here revealed that resource availability and competing priorities tended to be weaker in health center facilities compared to the hospital facilities participating in the program. Next slide. And then finally, when examining the conversation guide results, we found that action plans aligned well with points of variability and challenges that were identified through facility discussions, suggesting that the use of the tools helped our implementing partners identify these areas and then prioritize their action plans accordingly. The action plans that were developed included broad activities, but tended to lack sufficient detail related to specific tasks, timelines, people, and resources needed to operationalize these activities and hold people accountable to them. I wanted to highlight an example of an action plan that resulted from the conversation guide, which is at the bottom of the slide, but it's improving teamwork by addressing clinical roles and skills. Conversations with facility staff revealed that there was a deficiency in team culture that resulted from a lack of confidence and trust in team members' skills and knowledge of their roles. In response, Indonesia team facilitators created an action plan that mentioned increasing simulation-based practice and developing more clearly defined roles and responsibilities for midwives during maternal or neonatal emergencies in order to improve the levels of teamwork and help strengthen the overall quality of care that they were able to deliver to their patients. And with that, I'm pleased to hand the presentation over to Bu Nurul so she can describe her team's experience using the Context Assessment Toolkit.
Yeah, thank you, Megan. Firstly, I would like to thank Ariadne Lab for the opportunity for us to involve in this study. And also thanks for the opportunity for us to share our experience of using this tool. Before I share our experience in using the tool, I would like to briefly describe the MCGR program in Indonesia. It is a 4-year program aimed at reducing maternal and newborn mortality. It has 3 intermediate results, which include improving quality of MNH care, improving referral system, and ensuring policy support and the use of data for decision making. Some of the intervention to improve the MNH care include hospital mentoring for hospital, then facilitative supervision for primary health care. We also strengthening maternal and perinatal death audit. We also have work for referral system, for community engagement, and also improving data quality. In our work plan, in our year 1 work plan, actually we wanted to use this tool to identify and select the facilities that are ready to receive the intervention. However, due to some reasons such as project startup, recruiting staff, and etc., we were not able to really start the study to select the facilities. Instead, we decide to use the study tools to assess the contextual factors that may influence the success of the intervention in some selected facilities. How we did it? So the first thing we did through a series of discussion with Ariadne, by selecting the intervention focuses. We decided that we would focus on hospital mentoring for the hospital and facilitative supervision for the intervention in the health center. We also decided on the study sites. we would select, which include 4 hospitals and 6 primary health centers. They represented both urban and rural areas, as well as big and small volume facilities. We also involved in the preparation of the study tools, checking the translation that was done by a consultant at that time, also piloting the tools and involved in the revision of the tools. We got some online training from Ariadne on the study steps and how to collect the data. We then start the data collection. It was done mainly by our field staff. So we did it in very efficient way because we did not hire a consultant to do the data collection. Instead, we use our field staff. So our field staff introduced the study to our informants, which is health provider from management and staff in the hospitals and health center. Then we share the link to the survey so that they can fill in the questionnaire by themselves. Although in some facilities, the informant fill in the questionnaire, the hard copy, and we entry the data to the link. Then we also did the discussion to get the qualitative data. We see this tool is very useful as it assesses the characteristic and circumstances that show the facility readiness to improve their quality services. The factor assessed such as leadership commitment, the staff motivation, teamwork in the facility will really affect the successful implementation of the program. We see also that the self-assessment using the online tool is also good so that we can do this in a very efficient way. The tools are also easy to use in the sense that it is easy for everyone in the facility to fill in because they think that they are asked for things that really happen in the facility they experience. But we also see some improvement that maybe we still can do that. For example, the translation of the tool from English to Indonesia, it is not easy. So the wording selection sometimes is quite difficult to really translate a term in English into Indonesia because of difference, so that we cannot really find the exact translation of a word. That's make a big confusion. So during the informant filling in the questionnaire by themselves, then some of them just estimate what does that mean. So that's why we find some misunderstanding on the tools itself. So we need to improve this on ensuring that the translation is easy to understand by the informant. We also feel that we need more training from Ariadne on how to do the data analysis, so that because we think that in the future we want to convince the district to continue using this tool by themselves. So that's from me. I think that I want to share. Okay, we also have provided the result feedback from the result of the study to the facility provider, so that the first thing we did after conducting the data collection and getting the analysis of the data is provide feedback to the facilities as the study site. We will further explore the possibility of using this tool mainly by encouraging the facility to do it themselves through the district health office. That's our plan, and further we will still need the guidance from Ariadne to do this further. Yeah, back to you, Megan, please. Thank you.
Great. Thank you so much for sharing your experience, Bunurul, and for all of your collaboration. And thank you all today for the invitation to share these findings that are part of the learnings coming out of the Momentum Knowledge Accelerator. Today, I'm going to share with you the details of our evaluation, including the evaluation methods, as well as the qualitative and quantitative findings from our study on the acceptability, feasibility, and utility of using the Context Assessment Toolkit in low resource settings. Can you switch slides? So we conducted a mixed methods evaluation, focusing on the experience of two groups of stakeholders, facility leaders and staff, and they're the ones who took the survey, participated as participants in the conversation. And we also got feedback from Momentum and CleanCut implementing partners. And those were the people who administered the surveys, held the conversations, and led those conversations. Our qualitative data collection consisted of interviews with facility leaders and staff, and that focused on toolkit acceptability, feasibility, and utility. And we also held focus group discussions with Momentum and CleanCut implementing partners, really focused on toolkit administration processes, what support's really needed for them to be successful in this activity, and for other implementing partners in the future. For our quantitative data, we conducted very basic psychometrics for all of the pre-implementation survey data, and we administered surveys to implementing partners, focusing on their experience using the toolkit. This gave them the opportunity to give individualized feedback in addition to the focus group. Next slide, please. Facility staff participants viewed the context assessment activities really positively and expressed desire to continue these activities regularly. 96% of the leaders and staff saying they would participate again. So this really built on what Bunarul was saying, is that the facilities were interested and could potentially want to be involved in this activity in an ongoing basis. Among the findings worth noting, facility staff commented that the main value they saw from the context assessment was to identify gaps and opportunities for improvement at the facility, and for self-improvement and development of professional skills as they went through the survey and participated in the conversations. And thinking about different concepts about how the functionality of the facility. Facility staff also recommended including a wider variety of clinical and non-clinical staff to give feedback and participate in the activities to get even a broader 360 view of the context at the facility. And the majority would be interested in seeing progress over time. So doing a repeat assessment. We focus more at the baseline at the beginning of an intervention, but also seeing how these things change over time and what progress they're able to make in these areas. Next slide, please. We asked participants about individual parts of the Context Assessment Toolkit to better understand how to streamline and optimize the toolkit. When asked about their preferences, facility staff generally preferred the guided discussion over the survey. And why was that? They liked the ability to expand upon answers beyond what was possible in the survey. And they also really enjoyed coming together as a group to solve problems and felt that the facilitated discussions raised group awareness of the issues. The downside, as you can imagine in most clinical settings, is that it's difficult to get a group of clinicians together for a large conversation like that. And it's sometimes conflicted with clinical responsibilities and other logistical concerns, which was a feasibility concern. Next slide, please. Implementing partners. So these are colleagues at CleanCut and our team in Indonesia. On the other hand, they really preferred the survey because of the ease of its scheduling, ease of administration. And most of them thought the amount of time conducting the discussion was a bit too long. Particularly colleagues in Ethiopia, they decided to hold the facilitated discussion through one-on-one phone calls or internet calls. And that, of course, trying to get a lot of staff on one-on-one calls took quite a lot of time. And they felt that that was too much of a time burden, but that was kind of their decided way to administer. Other concerns with the guided discussion included difficulty managing big groups and ensuring that everyone was able to speak and give feedback on the context, in addition to feeling comfortable speaking in a big group and potentially with seniors, senior staff in the room. Implementing partners noted that while the training on the Context Assessment Toolkit was sufficient, they thought additional time is needed to practice conducting and scoring, especially the conversation guide. Next slide, please. In terms of understanding the questions in the toolkit, 78% of the facility staff found the discussion really easy to understand and appreciated the ability for the facilitator or for colleagues sitting next to them to clarify anything that they didn't understand. The questions and topics covered in the survey and the conversation guide are very similar by design. For the survey, however, facility staff noted that the use of the Likert scale, so the Likert scale is a scale where you go strongly agree, agree, disagree, strongly disagree, and you choose only one of those options. And they felt that that limited their ability to accurately answer the survey questions. Many actually asked for a neutral category of, a middle ground or a free text box to really go in depth, because maybe some aspect is very positive, but another aspect is very negative, and really wanted the ability to go in detail, which a conversation could help with. Time crunches, as you could have seen from other survey activities, can result in shortcuts, and the survey length made completing it challenging. We looked for straight lining, where someone might go straight down a page and say, agree, 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 agree. And we found that in about 7% of the respondents, answering the same response for multiple questions all in a row. Additionally, while it was rather quick to administer the survey, for implementing partners, staff noted that the questions required time to think about, as many were concepts that they hadn't really explored or been able to sit with. So actually being able to be thoughtful, it required additional time to kind of sit, and it really couldn't be done in the midst of patient care. Translation, as Bu Nurul mentioned, is something that came up as being a challenge for comprehension of the questions as well. Next slide. In general, socializing the idea of quality improvement was noted to be important in getting staff to buy in. Because some of the interviews were delayed, people may have been confused by the term quality improvement, because maybe that's not something commonly talked about, or the intervention itself hadn't started yet. Facility staff noted that their introduction to the context assessment occurred in a variety of ways. Some had an in-person introduction, some were introduced over calls or from text messages from facility or department managers and leaders. The introduction, given the feedback, was a little bit uneven, and facility staff mentioned really wanted a little bit more of a comprehensive orientation to the process so that they could understand. I think this is especially relevant as the toolkit does include several surveys and the conversation guide. And so to understand how those pieces fit together so they can best invest time and understand when and how to give feedback. Ensuring that staff know the purpose of the assessment, that it's really to identify gaps in order to work on them together. It's critical to improve participation rates and relevance. Otherwise, some of these topics can be seen as very sensitive and deter some of the participation. Next slide. In terms of utility, most implementing partners felt that the results reflected the reality at each facility. And they mentioned that there really were no surprises. As mentioned earlier, as we talked about with the toolkit, it was originally designed to really guide and improve implementation of a new practice change. Of note, the two implementing partners that we worked with had chosen to use the context assessment for different purposes, uses that they thought would be most useful for them. The Indonesia team had initially intended to use the context assessment at the very beginning of an intervention to kind of understand which facilities are ready to participate in hospital mentoring. Due to some delays, they did end up using it to start to guide their implementation. The team in Ethiopia thought it was really useful to conduct the context assessment activities and to use the toolkit in order to contextualize and explain the results of a study that they're doing, really looking at reducing infection rates with cesarean. Next slide, please. There are several limitations to our analysis. During the analysis period, before we were able to collect, when we did the interviews for the qualitative interviews, the results had not been shared back to the individual facilities. So they had participated in these activities, but hadn't really come full circle in using the toolkit. And that was due to time limitations of the evaluation and some delays in program implementation, as real life happens. They also need a little bit more guidance on the data interpretation that we had budgeted for in our timeline. That restricted our utility analysis so that we really looked at perceived utility rather than actual utility, and we would love to look at actual utility going forward. Additionally, depending on the site, the time between participating in the survey or the conversation and the evaluation interview was several months for some facilities, and that could have affected the level of detail that they remember about their participation or their perceived acceptability, feasibility, and utility of participating in the toolkit. And finally, our bivariate analyses of the survey data didn't account for all respondent characteristics. We had a very limited set of characteristics that we had collected. And so that limited some of our interpretation of that. So I really want to thank you guys for all participating and listening today. I want to pass this over to Adam Lindsley to discuss recommendations coming out of this work.
Thanks so much, Megan. So based on the findings of the pilot, we made certain key recommendations for improving the acceptability, feasibility, and utility of the Context Assessment Toolkit. These recommendations apply not only to us as Momentum Knowledge Accelerator in helping awards use the toolkit in the future, but also implementing organizations as they integrate and sensitize the context assessment into their work. So sorting through the data we collected, we were pleased to see that there were generally positive perceptions of the value of the Context Assessment Toolkit. Facility staff seemed eager to understand where they could improve on, and implementing partners felt that the toolkit reinforced the need to address certain issues and could be used to bolster support for these changes. But of course, there are areas that were problematic and that we are seeking to address. So Megan has already largely discussed the findings in some of these tables. So I want to focus on the recommendations in the second column coming out of the evaluation. One of the key recommendations coming out of the pilot is dealing with the use of results. Since we saw there was anticipation from facility staff on understanding and improving gaps and weaknesses, but there were delays in getting results back to facilities. In our future guidance, we are stressing that implementing organizations ensure that results are provided back to facilities in a timely manner and with suggestions for how to act on them. And because there was such enthusiasm for the guided conversation portion of the toolkit among facility staff, we are recommending that implementing organizations utilize the conversation guide in place of or to complement the pre-implementation survey, especially in facilities that may not have previous experience with quality improvement work. Because of the time commitment for facilitating these conversations, we want to stress their value to implementing organizations. And we understand that there could be dynamics at play that might affect what is shared during these guided conversations. So implementing organizations should consider offering separate discussions for leaders and staff to promote maximum transparency in their responses. In order to improve acceptability of the toolkit, there were a few recommendations we're making. One is that the tools be properly socialized, including certain quality improvement concepts in advance. Providing this more comprehensive orientation on the context assessment and quality improvement concepts in general would help to alleviate some of the confusion on the purpose of the activities. We have developed some resources to make orientation simpler that communicate what types of actions or changes might result from the context assessment toolkit. The other change we made was to simplify questions on the surveys and conversation guides. As Megan discussed, there were questions and concepts that were misunderstood, and we want to continuously learn and adapt the questions depending on various factors while maintaining the fidelity of the toolkit. In order to improve feasibility, the recommendations focus on toolkit administration and training. Since it's not always feasible that health facilities are going to have reliable access to internet, offering the option of completing paper surveys is an important element to increasing reach of the toolkit. Also, because of the time commitment for conducting conversations in a one-to-one fashion, we are not recommending this in the future, unless there are some important considerations that would allow for more insightful data through this method. Lastly, investing the time and resources early on in terms of how to interpret and operationalize the results is likely an important consideration. And on the next slide, I'll talk about some of the resources we have prepared to facilitate that. So one of the main components of utility that we were hoping to answer was how useful the results were to implementing partners. And as we have mentioned, although we are not able to fully answer that because of delays in program implementation, we do have some insight that there was interest in seeing the results and where facilities could improve. One of the big learnings for us was around analysis and use of the findings. We found that implementing partners needed more support than anticipated from us for this process, and this drew things out longer than planned. So in order to improve this, we have changed the survey results into a simpler format that can quickly be interpreted and shared with facilities. We have also added examples, strategies, and resources for how implementers and facilities can use the results to adapt program implementation and fuel improvement. We feel that this was a key missing piece beforehand, And being able to speak to the so what of the results will empower implementing organizations to run more independently with the toolkit. Those are the findings that we found through the evaluation. I am going to hand it over to Bu Nurul for one more time to talk about their experience in delivering feedback to the facilities. Over to you, Bu Nurul.
Thank you, Adam. I don't think I have a lot to share for our experience in providing feedback to the facilities. In general, we got very good acceptance from the facilities. We have done the feedback to all facilities, the 10 facilities in NTT province. And we see there has been no objection on the result, for example, of the study or the from the respondents. So they admit that the finding is actually represent the real situation. We also happy that we noticed that some of the facilities have done some action based on the result. For example, for the resources that they don't have, for the data that they need to share, for example. So we see some action already take place from the result of the study. We also, during the feedback to the facilities, we also get some verification and also some correction on the misunderstanding of the tool that I have mentioned before. They say that, no, that's not what we say, because that maybe because we misunderstood the survey question, something like that. So that's what we get from providing the feedback to the facilities. We have not done the feedback to a wider audience. That is our plan to do the dissemination on these tools and the study result to improve our intervention. Hopefully, we can do that in our next dissemination meeting, which will include district health office and also stakeholder at province level on the use of this study tool for improving quality of care in the facilities. Yeah, thanks, Adam. Back to you.
Thanks so much, Bu Nurul, for that really insightful learning from your program in Indonesia. So we are actually going to provide just some space for a Q&A right now. I see there's some questions that have already come in through the chat, so I'm going to actually be kind of grouping them a little bit together, as there are some questions that are similar in nature and theme. And then we can continue to ask more questions as they come through in the chat or in the Q&A. So please continue to enter them. There are some questions that have already been answered, which I will read after the fact, just out loud for the sake of our Francophone colleagues, for the interpreters. But right now I'm going to start with the unanswered questions. So for our panelists, there's a lot of questions about kind of the recommended time it takes to implement the tools, and then when the timing of when certain tools should be implemented. So from let's just start with this first question here. How much time did it take to implement each tool in the facility, in practice in the field? And then what is the recommendation you would have? Like, what is the ideal time when using the tool, and then between use of the tool and sharing the tools with facilities?
I can answer the ideal time frame part, Megan. I don't know if you want to speak to how long it took for the implementation of the tools for the pilot period, but ideally, the pre-implementation and conversation guides would be implemented in early implementation. So this is the period of time where a improvement has been selected, a solution, a health problem has been identified, a solution has been identified. You would want to then introduce the toolkit at the facility where the improvement is likely to be implemented, and collect that feedback and deliver those results back to the facility to stimulate a conversation around next steps. So we want to gather this pre-implementation data early on in the process in order to be able to make changes, in some cases to the improvement work itself or to our proposed implementation strategies to better reflect the current state of the facility that wants to use this improvement work. So that would be done in ideally maybe the first 2 months of that early implementation period, again, after a potential solution has been identified. For the other tools, the progress survey, we recommend doing that either midway through or towards the end of what we call the active implementation period. And this is when activities being performed to actually introduce the improvement work into the facility are ongoing. So the progress survey can be used to monitor progress of the implementation itself and also see if there are changes in any of the contextual domains that have occurred over this period of time. And then the implementation pulse check is actually we're recommending it be a quarterly discussion among implementation team members at the facility itself. And this is just a progress check for how are the implementation strategies moving forward? What are current or potential emerging risks that we as an implementation team are seeing that may impact the success of this improvement work? So that's kind of an overview of an idealized timeline of when we see using the various tools in the toolkit.
Thanks, Megan.
I can jump in a little bit as well. And Bu Nurul, I don't know if you want to talk with your experience about how long, like how many minutes it took for the conversation or for the survey. As we were imagining it and piloting the conversation, it took about 20 minutes. You can imagine a conversation with leader has 10 questions. You know that they have to go, they're very busy, so you want to try and get it in quickly. I think each of these conversations took a bit longer than what we had initially expected. And especially with staff in a large group, those conversations, I recall taking about an hour to an hour and a half to really facilitate them. The survey really depended on when and where the survey was done, but the survey usually can be done within 15 minutes or so. Obviously, some people are going to take longer, and as you're reading it, some of the concepts might not be familiar, and that was some of the feedback that really maybe it should take a little bit longer. Bu Nurul, anything to add there?
No, I think that's that we also have in Indonesia when doing this. It's not it didn't take that long to fill in the online questionnaire, and the conversation, the discussion, take place for an hour or an hour and a half. Yeah, that's the average time that we have. Yeah. While for the feedback itself, yes, we have a bit delay in providing the feedback due to some reasons of the activity, so that we just piggyback what the meetings, for example, not really following the ideal timeline for providing feedback, for example. So we just try to find the convenient time that we piggyback other meeting, for example, or when we have a schedule for visit the facility for other purpose, and we use the time to provide the feedback. That's the situation that we have in Indonesia when using the tool. Thank you.
Thanks, Bunurul. I'm actually going to ask a question because that's actually a good point. I think it would be helpful to hear exactly this point about how easily it was to integrate those conversations in those regular meetings you were already planning. So was it difficult, for you to add on these topics or these conversations with those regular meetings and that you had already planned in the facilities?
No, we didn't find any difficulty in what you call it, integrating or combining our purpose to visit the facility for example, for checking the data that because we also collect routine data from the facility for our project purpose, so that we use the time to visiting facility to also ask for a meeting, for example. We can combine that to activity so that we don't we can use our resources efficiently. That's our consideration. Yeah.
Thank you so much. Okay, I'm going to jump to a few questions here, and sorry that it's not in order with the way that they were applied in. I'm just trying to group them together here for common responses. So you've talked a little bit about the dissemination plan for the results of the evaluation. Could you speak a little bit more about who you're trying to reach with the dissemination and involved in the dissemination of the results?
Yeah. Yes. What we have done is only providing feedback to the study site, which is only 10 facilities. We plan to convince the local government, which is the district health office, to support the use of this tool further. Of course, we plan to have the dissemination aimed at convincing them to continue using this tool. Of course, we believe that we will improve the tool so that and also we need to mastering the tool ourselves before we really disseminate this to the district health office. But yeah, so it will be we plan to do the dissemination soon, but we don't know yet the exact time to do that. But it is to the district health office and also to province health office, the stakeholder at province level, so that they support the use of the tool. Yeah.
That's great, thank you. And since you do have the microphone, I'm going to jump to another question about implementation and continued implementation for the tools that are planned. So we do have a question about if you have plans to reapply the tools in Indonesia to see if the tools continue to yield more useful information, either to track progress against the action plans or to give guidance for future activities.
Yeah. So for we only, because of the time that we have, because of the delay in the implementation of our intervention, so that we didn't able to really use all the series of survey. For example, we only use the conversation guide, not yet the progress survey and also the post check. Actually, some of the facility already at least one asked, so when will be the progress survey? That's the question from our team. So when we will do this progress survey to continue the process. Yeah, that's the question. But as for other facilities using this for other facility, that's what we plan to go through the district health office. So not by ourselves, but it is by themselves, not by us, the MCGL, but by the district health office, by the facility themselves. Because yeah,
Yeah, that's great that you're attempting to institutionalize the use of the tools.
Yes, yes.
So that's
yes.
wonderful. Thank you. So maybe I'll jump back to questions to the research team here. There was a clarification, there was a question already answered about the differences in survey responses between the countries. And the question here is clarifying that and asking if there were differences seen within the responses about the ways that providers maybe were responding to the questions in Ethiopia versus the way they responded to questions in Indonesia. And if you saw any differences in those I guess, experiences.
So there were no main differences between country level differences, specifically with the question. There was some very distinct differences in the populations of each country. So most of the respondents in Indonesia were female. And that kind of reflects some of the maternity focused activities that were going on, whereas the colleagues in Ethiopia are mostly a surgical team because they're working on cesarean delivery and improving reducing surgical site infections. Most of that team was male. So we did see that the country population that took the survey was different in each place. We did find some differences between the leaders and the staff. And specifically, the differences were really around the quality of teamwork, respect for quality improvement work, knowledge of roles and responsibilities, support for implementation team. So we saw some differences between roles, but those were fairly similar across the two different settings that we looked at.
Thanks. And then another question for you, Megan, or Megan Elam. Could you maybe describe any plans to decentralize data analysis and reporting of the information collected through the tools so that implementing partners can be more in control of the data that's coming from the tools themselves?
Yeah, that's a great question. This is work that we have only just started here at Ariadne. We have an online learning platform called Aria, where we have just completed kind of the first iteration of being able to get some of the surveys and reports onto this learning platform where potential users can access them independently, both the survey links and then the resulting reports. And we would love to be able to continue to expand this work so that lower resource settings, including the momentum programs, will be able to do something similar in the future. So it's definitely a goal of ours. It's just a matter of how long it takes to get done. But yeah, we would love to be able to make it more independently available so that people can access their own survey links and their own data.
Thanks, Megan. And that's
just
actually
to jump in here.
Yep.
Oh, sorry, one last thing. The conversation guide in and of itself doesn't require that system. So the guide itself is meant to be used and analyzed right there with the team. And so that the team itself doesn't rely on anything through Momentum Knowledge Accelerator or an outside source, and can really start to use the results right away. So that'll be a great pairing once the survey comes online.
Absolutely.
Go ahead.
Thanks, that's really helpful. And actually, that's actually a good pivot back to Bunarul, if you don't mind taking the hot seat again. Speaking about how, if making the data available and being able to review the responses with the staff in live while during the conversation guide. Could you maybe discuss a little bit about any further examples of actions facilities are planning to take as a result of the dissemination findings you just shared recently with the facility staff?
Sorry, Gerbil, I was a bit distracted.
No problem.
Yeah. Maybe I get your question wrong, but yeah, when we provide the feedback to the facilities, we noticed that some of the facility already do some action from the after the conversation, after the discussion. Of course, not after the survey, because they don't realize what are the result of the survey, right? Because they fill in themselves, each of them. But after the discussion itself already, what you call it, already trigger an action, some action. For example, they realize that, oh, we don't have the computer for the data, for sharing the data, something like that. So that, oh, we don't have equipment, something like that. So that from the discussion itself, before we really provide the feedback, the discussion among staff itself already trigger some action. So that during the feedback, when we provide the feedback, we got that information that some of the facility already take actions from the process.
That's really wonderful. Thank you. And I just wanted to make a note that another participant, our colleague Esther Khanna, actually also responded similarly. And just to flag, it said that they said that the health facilities also helped with procurement of computers and case simulations for capacity building among staff. So that's great to see that the facilities were so proactive in making those changes already themselves. And similarly, we had a question that noted that there was, I guess within the discussion guide or with the surveys, that in the facilities, there were recommendations made to prevent high staff turnover. Could you describe maybe in the action plans what those recommendations or plans were to help address high staff turnover in facilities? I don't know if that was in Indonesia or in Ethiopia. So actually, Bu Nurul or the Megans, if you have any idea of that.
No, I don't have answers for that question. That's quite difficult. Actually, we also suggest during after conducting the study, we have discussion, right, with you all. One of our suggestion actually is to get the idea when we provide the feedback. If this is the problem, what will be our strategic what you call it, feedback or a suggestion or recommendation. That's the thing that we may want to, as you also mentioned in the, as we also have in the slide before by Adam about the recommendation. We as the one who do the data collection and providing feedback, sometimes we feel that we are not really ready to provide the suggestions to the facilities. Yeah, that's the. Thank you.
Yeah.
Sorry, not answering your question. Sorry for not answering your question.
No, that's helpful to understand. It's a big question mark, I think, for many people.
Yeah.
I think just to add a little bit more here, I think that the context assessment toolkit is going to raise a lot of questions within a facility. And I don't think it's necessary to say we need an answer for each one of them. For the staff turnover, this has come up in many settings. You know, it's a challenge around the world right now with staff turnover. But really thinking about, you know, as you're implementing a mentoring program, if there's very high staff turnover, what do you need to think about in order to make the program more sustainable? Is there more frequent training? Is there, how are we going to onboard people as they come in, you know, quickly? I think it's not just like, how do we stop staff turnover? Because that is a bigger problem that I think maybe this is not meant to tackle. But I think it's more, okay, we know now that they're turning over nurses every 2 months. You know, how are we going to adjust so that we don't rely on a nurse who's then going to go somewhere else? Or how do we use that to our advantage? If nurses transfer, can we spread this type of information through this natural dissemination? I think it's starting to think about, you know, some of the natural things and some of the things that are going on, the context at these facilities, and trying to understand how it might positively affect, or how you can adjust to, and adapt to make the practice change successful and then sustainable.
Thank you so much, Megan. Okay, so pivoting to another question here. We have a question. I'd like to understand how much the findings of the assessment could be used to develop broadly generalizable facility archetypes.
That's another really good question. And I think this is one that, from a research perspective, the context assessment team is really interested in learning more about. Our hope is that as we continue to use these tools and learn from our partners who are using these tools, we'll be able to get enough data to do some more of these predictive analyses, especially on these different contextual factors, to figure out which ones are really the biggest drivers of implementation success. And then through that work, we may be able to make more predictions around facilities that are really strong in commitment and motivation and ability to implement are more likely to be successful. But right now, we don't have enough data to make those predictive analyses, but we look forward to continuing to learn with our partners as they continue to use the toolkit and build on kind of those predictive aspects of hopefully this assessment.
Thanks.
I think, sorry.
Go ahead. No, go ahead.
I think other implementation organizations, sometimes it might not be able to be totally global, and these things are definitely consistent across every single intervention. But I think implementing organizations have the opportunity to even learn within a specific practice change as they spread across many facilities and understand, the feedback from these facilities might need this type of support, or the feedback from those facilities might need a different type of support. And I think, colleagues from Ethiopia with CleanCut are starting to use this in different settings in Rwanda as they think about surgical site infections and what contextual factors there might relate to what they found in Ethiopia, and kind of spreading practice change and trying to learn so that they can really allocate resources more effectively.
Thanks. Yeah, it seems like a lot of the impetus here is that the tools themselves just really encourage a lot of conversations and discussions that staff don't have the time usually to reflect on together or even individually. So similarly with that note, there is a comment about that facility participants in their responses to for the evaluation overwhelmingly seem to appreciate those conversations, which is a great reflection, I think, of kind of that, a little bit of that behavior change or thinking. And then our last question here is kind of a doozy. So for the facility responses, could you share some reflections on how much the responses actually reflects how the toolkit was implemented and rolled out versus reflections about the usability or feasibility of the toolkit itself? So how much of the findings was affected by implementation versus reflection of the tools?
And the actual survey results themselves?
Or the results from the evaluation, I think from the focus group discussions with staff or the interviews with facility staff and their kind of perceived reflections of use of the tools. Is how I understand the question.
Sure, no, it is absolutely a good question. I think it's probably both. Bunarol did mention earlier that when sharing the context assessment results back with facilities, there weren't a lot of surprises. So, which to me says, regardless of how the toolkit was implemented, it seems to reveal fairly reliable, fairly consistent information with what people who are more familiar with the facility know is going on the ground, which is really helpful. I certainly do think, as Megan mentioned, in some of our limitations, the length of time between when the toolkit was first introduced and when we did some of these follow-up interviews and evaluation pieces could have certainly impacted the types of details that were recalled from participants. which certainly could have impacted the evaluation results. So I'm certain, that part of the implementation process, I'm sure, somewhat influenced our results. Megan, anything else that you want to add? Or Bunurul, from your experience?
No, I don't have any to add.
Thanks.
I think that
Go ahead. Sorry, Megan.
I think that the toolkit itself in rolling it out does start to build relationship.
Mm-hmm.
And I think that those relationships have the potential to be, needed in building trust and building understanding of what's coming. And so I think the rollout and the toolkit itself is very close in how they operate. But I do think that many of the topics seem to resonate as topics that don't necessarily come up in a typical staff meeting. And that was some of the benefit, not just in having any conversation, but in having this conversation that seemed to be useful and different. And I think that's one thing we can walk away with.
Mm-hmm.
And then we just have one last question from our technical director, Laura, here. So kind of going back to an earlier question, Megan Marks-Laney, about the use of the toolkit and possible development of archetypes, facility archetypes. Does developing archetypes go against the idea that context matters, though? Do we risk ignoring unexplored contextual issues if archetypes are developed? This is more of like a larger conceptual question about the tools themselves. So any thoughts?
I love this question, and it's something that we have definitely struggled with, but I think it really comes back to what's feasible and what's a good use of resources. Well, I think it would be great to really kind of do this activity across every single facility and really, cater to each facility. And I think in some settings that might be totally reasonable. And feasible. Whereas in others, it's going to be a really hard stretch of resources. Other organizations that we've talked with say, we don't think we can do all of this in every facility as we're spreading. But we can do it to kind of start to figure out how we can do this initially, and then understand maybe some of the archetypes and a lighter touch version that might be used as we continue to spread. So this is a great question, and I think that's one of the reasons we've developed a toolkit, with surveys that could be used in one way, conversations that could be used in another way. It's not just one thing. And I think we're really trying to understand, how this can balance understanding context, but also being a reasonable use of resources and time, which are so precious at these facilities. So thank you so much for that question.
Thank you so much. So now actually we're going to pivot to what this means for kind of next steps for the Context Assessment Toolkit itself, and what Momentum Knowledge Accelerator and the Momentum programs could possibly do with this information to further adapt the tools and learn from possible future applications. So I will turn the mic back to Adam.
Thanks, Gabby. And to wrap up, we will be sharing revised versions of the surveys, of the conversation guides, and other supporting resources that have been revised in the coming weeks. I realize that work planning for the next project year is largely complete for Momentum Awards, but if you think that your project could benefit from the Context Assessment Toolkit, please reach out to us through MacLab for support with rolling this out. And as with most toolkits, this is a living process. We've talked about constantly learning from the data that we're seeing. So it's going to benefit from continued use and refinement. So we are eager to see it applied to other contexts. And for non-Momentum organizations, you can reach out to our colleague, Megan Lam at Ariadne Labs for more information. So thanks. I'll hand it back to Gabby.
Thanks so much, Adam. Yes, so we will be sharing some of these tools out to our partners and colleagues here on this call and under the Momentum Awards. So thank you so much for everyone who has attended today. Please look out for further emails with further resources and sharing of information and learning. And I'm just going to enter in, if you don't mind, all kind of responding to a quick survey just of how the webinar went. That would be really helpful to us. I'm going to ask that my colleague, either Maya or Devin, enter this link into the chat, because I, as a host, don't have access to the full chat right now. But if you could take 2 minutes before you sign off just to answer our survey, that would be really helpful. And thank you again. Please reach out to us if you have any questions or further comments about how this tool could be used in your own programming. Thank you. And thank you to our panelists.
Thank you all.